Glad to be with you. My name is Dr. John Kelly, and today I'm going to be talking to you about drugs, stigma, and policy, how and why words matter. Just in terms of a little bit of a personal introduction, I am the Elizabeth R. Spallon Professor of Psychiatry and Addiction Medicine at Harvard Medical School, and I'm also the founder and director of the Recovery Research Institute at Massachusetts General Hospital in Boston, where I also serve as the Associate Director of the Center for Addiction Medicine. I am a former president of the American Psychological Association Society of Addiction Psychology. I'm a fellow of the APA and a diplomat of the American Board of Professional Psychology. I've been a consultant to US federal agencies, including the National Institutes of Health, SAMHSA, as well as foreign governments and the United Nations. And I've published over 200 peer-reviewed articles, reviews, and chapters and books in the field of addiction medicine. And I was one of the authors on the US Surgeon General's report on alcohol, drugs, and health. I'm also a clinician seeing patients weekly. A lot of my research work has been focused on addiction treatment and the recovery process, mechanisms of behavior change, how treatments work and how people recover, and reducing stigma and discrimination among individuals suffering from addiction. And it's really that latter part I'll be talking to you about today. Just in terms of disclosures, I am a full-time faculty member in the Department of Psychiatry at Harvard Medical School and Massachusetts General Hospital. I've received an honorarium for this presentation, and I have received funding from these federal agencies, NIAAA, NIDA, and IMH, SAMHSA, Department of Veterans Affairs and state agencies to conduct research on addiction, treatment, and recovery, and I do not have any conflicts of interest in today's talk. So I'm going to talk today about stigma, which is a huge issue, of course, when we consider the drug problem, quote unquote. Every time we think about alcohol and drug problems, we have to address stigma and discrimination because they go hand in hand with addressing these endemic problems in our society and around the world. I think, I've just been reflecting lately, the last year or two, over the last 50 years, because it's actually 50 years since the declaration of the war on drugs under Nixon, right now in 2020. So that's 50 years. So I've been zooming out a little bit and just reflecting on, what's happened in this past 50 years. What have we learned? What do we still need to do? A lot has changed. We've learned a lot. The founding of NIAAA, NIDA, SAMHSA, CSAT, all of these agencies have come along since the 70s, early 70s, mostly in terms of NIAAA and NIDA, produced a ton of research in terms of our understanding of etiology, epidemiology, clinical course, the treatment, and recovery from alcohol and other drug use disorders. I think notably, and I think relevant to today's talk, is that our rhetoric, our language, our approach has changed over this past 50-year period. When we think about Nixon, who famously declared drug abuse, quote unquote, as being public enemy #1, used that harsh rhetoric that was common in the 70s and 80s, the tough on crime approach to drugs as well as other crime, that kind of law enforcement, militaristic rhetoric was very common. I think today we would not describe the drug problem as public enemy #1, although some people might. I think the majority in society would describe it as the top public health problem. So still #1, but a shift away from the kind of the classic punitive approaches of the war on drugs towards a broader public health approach. If you review our legislation that's been passed over the last 50 years, this shift in legislation also reflects that. In terms of the shift from this more punitive stance that is captured in the mandatory minimum sentences of the Anti-Drug Abuse Act in the 80s, through more recent laws such as the Mental Health Parity and Addiction Equity Act and the Affordable Care Act, both of which were about increasing access and availability of services so that people could get help and get help sooner without the burden of personal payment. This was underscored in the first ever National Drug Policy Reform Summit held at the White House on December 9th, 2013. I was actually at this conference, and I presented some of my work that I'm going to talk to you about today on stigma in language and how that relates to this issue of drugs and drug problems. I think the world is changing. I was also at the United Nations in January in Vienna talking about this very same issue that I'm going to talk to you about today, about stigma, discrimination, language, and policy. And if you look here, this is right outside the United Nations building in Vienna. On the bottom right-hand side here, you see that monument. This is the only monument that's highlighted outside of the United Nations building. Interestingly, look what it says. It says dedicated to all those affected by drug problems worldwide. Drug problems are preventable and treatable. How interesting is that? Outside the United Nations Office of Drugs and Crime, there is this very kind of humane message and dedication dedicated to those affected by drug problems worldwide, that drug problems are preventable and treatable. And I think that is noteworthy. We've also seen a shift nationally in the United States in terms of our approaches to the drug problem. We have moved away from the harsh, blind, racist policies around locking people up, mostly black and brown young men, for drug problems, to diverting them to treatment through drug courts. So being able to provide treatment to the extent that these crimes are driven by addiction, that we can actually make a smarter approach towards helping people get back on track in their life through drug courts. This has been a big shift. Also, somewhat surprisingly, even police chiefs themselves recognize that the harsh approaches of the war on drugs, the more punitive approaches associated with the war on drugs, are ineffective. This was a police chief in Gloucester, Massachusetts, on the North Shore of Massachusetts, who actually made national headline news by recognizing that it's no good, does no good to take people who are addicted and lock them up. So what he did was create this thing called the ANGEL program, help, not handcuffs. The idea was if you had an addiction problem and you came to the police station, you would be taken to treatment, not to jail. And again, right at the front line here, police chiefs and police officers on the front lines recognizing that the best approach for addiction is not incarceration, but rather to help people get the treatment that they need. So these shifts that have happened over the last 50 years have been really a reflection on policy analysis and the effects of different policies and how these endemic problems can be best addressed. And don't forget, to lock someone up is not cheap either. It costs a lot of money, anywhere from $15,000 to $60,000 a year to keep someone in prison. The question is that an effective form of correction? It's supposed to be the correctional system. Does it correct behavior? And I think most people would agree that it has not been an effective deterrent or an effective strategy to help people, quote unquote, correct their behavior, in part because a large proportion of those who are imprisoned have mental health and addiction problems that have driven the crime or are related to the crime. So that brings me around to this kind of topic, of course, that's all related to this topic of stigma and discrimination, because it's really, I would argue that it's a misunderstanding of the nature of many perceived crimes in terms of the drivers of those crimes that has been ineffectual in terms of policy decisions. So what is stigma? Stigma is an attribute, behavior, or condition that is socially discrediting. And what is discrimination? Discrimination is the unfair treatment of individuals who have that stigmatized condition. And stigma can take many forms, of course, and it can have many different consequences, both at the public level and at the personal level. In terms of the public level, it can produce and lead to differential public and political support for treatment policies. As I mentioned, it can sway public opinion and politicians' opinions regarding which is the best approach. Should we be tough on drugs? Should we present these mandatory minimum sentences? Should that be the way to go? Or should it be the way we have actually gone? Should we support broader public health approaches for prevention, for treatment, early intervention, and recovery support services? And stigma can make the difference, and how these disorders are perceived and conceived can influence those policy judgments. It can create barriers, of course, to employment, education, and training, and reduce housing and social support, and increase social distance. On the personal level, it can lead to internalized shame, guilt, low self-esteem that can reduce the acknowledgement of having a problem. It can reduce the disclosure of that problem so that people can seek help, and it can delay help seeking, as well as lead to premature dropout from treatment. In terms of the commonly studied dimensions of stigma, these are those: blame, prognostic pessimism or optimism, dangerousness, and social distance. So blame is one, is in terms of, are they responsible for causing their disorder? And of course, this comes into play big time for alcohol and drug problems, because of course it does involve initial decisions to use. And that exposure, of course, through genetic predispositions can be amplified, and I'll talk about that. But prognostic pessimism or optimism, can people who have this stigma, can they get well? If they have a alcohol drug use disorder, can they actually get well, lead a normal life, not be perceived to be dangerous, and therefore to be ostracized or to be separated from us? And these are the other dimensions: the dangerousness. Are they unpredictable? Can they ever be predictable? Are they safe to be around? Would I have them as a neighbor, as a co-worker, as a husband or wife? Would I have them marry into my family? Would I have them as a babysitter? So these are kind of common dimensions of stigma that have been studied. Now, it turns out that substance use disorders are possibly the most stigmatized conditions in many different societies. This is a study conducted by the World Health Organization in 14 countries, 18 of the most stigmatized conditions. This included conditions or problems such as being HIV positive, having AIDS, being a criminal, as well as use of illicit drug addiction, and alcohol addiction, the domesticated drug. And of those 18 most stigmatized conditions across 14 different societies, universally, number one was illicit drug addiction. Number 4 in the list was alcohol addiction. So 2 addictions, one illicit, one licit, both ranked up there in the top 4, with illicit drug addiction being the top most stigmatized condition, even above being a criminal. What else have we learned about substance use disorder and the stigma surrounding it? Well, we do know from lots and lots of studies that substance use disorder is much more stigmatized compared to other psychiatric disorders. And in part, it's because, on the top right here, compared to other psychiatric disorders like major depression, PTSD, schizophrenia, bipolar disorder, etc., people with SUD are perceived as more to blame for their disorder because, again, I think there's this issue of initial choice, that they did it to themselves, so therefore they should be blamed more. The middle on the left, describing substance use disorder as treatable, does seem to help. In dozens of studies where that's been depicted and describing it as a treatable condition does seem to help, particularly in reducing the danger and social distancing. In terms of patients themselves who hold more stigmatizing beliefs about substance use disorder, they are shown to be less likely to seek treatment and also to drop out from treatment sooner. And also, physicians and clinicians are shown as well, just like other members of society, to have stigmatizing biases against those with substance use disorder. They often, in systematic reviews that have been done, they view substance use disorder patients as unmotivated, manipulative, and dishonest. And substance use disorder specific training, however, does seem to help with this. And I'll come back to that issue of education later. because that's one of the ways that we can begin to chip away and address stigma. So why is it that addiction and substance use problems are so stigmatized compared to other social problems and health conditions and other forms of mental illness? Well, I think it has, as I've alluded to already, it has to do with two dimensions. One is cause and the other is controllability. We tend to, if we can say that a disorder or a condition or an attribute is not their fault and they can't help it, stigma tends to decrease. If, on the other hand, we say it is their fault, they did cause it, and they can really help it, then stigma tends to increase. And of course, when we think about substance use, as I've already mentioned, it does involve that initial imbibing of the substance, introduction, that has to involve a personal decision and a choice to take it. And then, of course, a cardinal feature of addiction, of the moderate and severe substance use disorder, is this inability to regulate the impulse to use despite harmful consequences. So that issue of controllability, although it might be there in the beginning, it is increasingly impaired, so much so that people actually can poison themselves to death many decades before Mother Nature intended. And this just shows these two dimensions here, correlated dimensions in terms of stigma, cause, and controllability. So let's address cause for a minute. In the last 50 years, one of the things we've learned since the birth of NIAAA in 1970 and NIDA in 1974, through dozens and dozens now of genetic studies, that like other complex illnesses, addiction, substance use disorder, is strongly genetically influenced. Roughly half the risk of conferring a substance use disorder, the onset of a substance use disorder, is conferred by genetics. In fact, one of my colleagues says, the question may not be why do people become addicted, but how come we're all not addicted, given that the large majority of the population are exposed to addictive drugs. Take alcohol, for example. Roughly 90% at some point in their life, 90% of the adult population have been exposed to alcohol, but only about 20% of those will actually meet criteria for an alcohol use disorder. And certainly addiction, only about 15%. So we do know then, in terms of cause, that the initial exposure that people make the choice to, they choose to imbibe it because of social custom or peer pressure, leads to that initial consumption. But it's the genetics which modify the experience, the subjective experience of that initial exposure. And people themselves who may be susceptible to addiction don't realize they're getting a more profound effect, which makes them pay attention to that experience much more keenly and then want to seek it out again. Not only that they metabolize it, some people metabolize it much more readily. And so they need more to get the same effect. They have this congenital a tolerance to alcohol that other people do not have. They don't have that sensitivity that other people may have, and that's genetically modulated. And so we do know, like other complex illnesses, there is a strong genetic component which influences the causal aspects. And this is important because it helps us to understand and reduce blame when it comes to stigma. What about controllability, the other dimension I mentioned regarding a factor that affects the degree of stigma? Well, we've also learned a lot from neuroscience in the last 50 years, right? We've all seen these nice images. This is not particularly, this is a cartoon as opposed to an actual image, just to show you the neurocircuits here that are involved in addiction that we've learned. But we've learned a lot about the neuroplasticity, the fact that the brain changes as a result of experience and as a result of chronic exposure to very potent substances like psychoactive drugs. And over time, the brain actually tries its best to adapt to these abnormally high levels of reward and reinforcement produced by psychoactive drugs. So much so that these adaptations become maladaptations. Also, through processes of neurotoxicity, brain cells can die, and the structure of the brain can also be altered detrimentally. But we understand much more readily today the exact nature of how drugs affect the brain and how the neurocircuitry of the brain of the reward, memory, motivation, impulse, control, and judgment shown here are affected. So much so that, as I mentioned, people are using against their will. So they will swear off it, they will try to stop, and still that locomotive has left the station and they find themselves unable to put the brakes on sufficiently to stop the pattern of use. And this is why oftentimes in the severe cases that we need to supply treatment medications as well as other kinds of behavioral support and sometimes residential treatment to isolate them from exposure. Also through neurotoxicity, through changes in brain structure, not just function. These changes shown here on the right, you don't have to look very long or very hard to see just the radical ways in which the brain can be affected through chronic exposure, in this case, to alcohol. And so when we see images like that, it helps us to understand a little bit regarding these factors of controllability, that it helps us to understand why is it that people who have this chronic exposure to alcohol and other drugs actually may find it very difficult to inhibit that impulse to use, despite very severe and harmful consequences, because the brain has become impaired. Now, the good news is that recovery in most cases is quite possible, and that's something I want to return to a little bit later. But because it looks like when we focus purely on the fact that these are disorders that affect the brain's neurocircuitry and structure, that if we leave it there, if we put a full stop at the end of that sentence and don't talk about it anymore, that is likely actually to increase stigma, interestingly. It actually decreases one type of stigma and increases others, as I'll show you. So what can we do about stigma and discrimination in addiction? I think there are three major things that we can do to help diminish stigma and discrimination. One is education. So presenting the data, like I'm trying to do now, around what we've learned about these disorders, the way that historically perhaps we've stigmatized other disorders that we've later come to understand are of a different nature than we once thought. I think the same will be true of substance use disorders, as we've now learned a lot more, and we're going to learn more probably in the next 50 years than we know today, of course. So education about the nature, the onset, the cause, the controllability aspect, the brain neuroplasticity, and so on, that's been important in terms of addressing stigma. Personal witness is another one. This social exposure to people who have the disorder. This has been a major thrust of the recovery movement, putting a face and a voice on recovery. As one of my colleagues says, it's hard to hate up close. When we get close to people, when we expose to people who have a disorder or a stigmatized condition, we start to, our stereotypes get dismantled, our beliefs get changed as a result of this exposure. And through this exposure, seeing people who smash our stereotypes, seeing that over and over again has been a major way that stigma can be addressed and has been addressed in mental health and addiction. And another way is changing and shifting our language, because our language implicitly drives our attitudes and behavior towards and policies towards these conditions. So here's some twists, though, in this story I'm telling you. Here's a question. Might then greater biomedical emphasis and explanations help reduce stigma, right? So if we talk about addiction as a disease of the brain, for example, does that actually help? Does it help if we talk about it as a chronically relapsing brain disease? Does that help reduce stigma? Well, let's have a look. There's been some quantitative reviews. This is a meta-analysis that's looked at this in the mental health field. And what they found in this quantitative review, 28 studies, okay, aggregated, meta-analyzed, and they were looking at biogenetic, so looking at the genetics. Remember I talked about that as a factor of the cause of substance use disorder? Well, it's also a major cause, contributing factor for other mental health disorders, right? So when you emphasize that, what happens? Well, what they found when they looked at these stigma indices that I mentioned, blame actually does go down. So that's good news, right? So if we actually talk about the fact that, which is true, that these are diseases, that they have genetic influences, helps to reduce the blame, and it does seem to reduce the blame towards those individuals. However, here's the kicker, is that it actually increased social distance, stigma, dangerousness, perceived dangerousness, and prognostic pessimism, the perception that people cannot get well from these disorders. Okay, so that tends to increase social distance because people fear the fact that people are unpredictable. Okay, so this is a slight twist, isn't it? You know, in some ways it's reducing, when we emphasize the genetic aspects, reduces one type of stigma, but not others. What about cause? So this is a quantitative review again, but this time it's looking at neurobiological explanation. So this kind of pertains to that issue of controllability I was talking about, those two dimensions, cause and controllability. So genetics is the cause, as neurobiology is to controllability. So I'm talking about the neurobiology. And if we emphasize, this meta-analysis was looking at, if we were to emphasize the neurobiological aspects, would we affect stigma? And which aspects of stigma would we affect? Well, it turns out that when neurobiological aspects were emphasized, actually none of the stigma dimensions were affected positively. So social distance, dangerousness, and prognostic pessimism all tended to increase, and it had no effect on blame. So it didn't affect that one way or the other. So somewhat surprising, right, in terms of what we might really think might be a positive. And so this, again, leads us to think a little bit more deeply about the nuances of presenting this information, how to present what information, when, and to whom. Now, those were in the mental health field. What about in addiction specifically? So this is a study we've just completed, should be out soon. But here we were actually trying to find out what kind of terminology, which kind of language, which ways of describing substance use disorder, in this case it was opioid use disorder, what's the best way to describe it in terms of reducing different types of stigma. And we had 6 different terms that we randomly assigned to a general population sample in the United States of roughly 3,500 participants. So roughly 600 each of those participants at random received a vignette describing someone in treatment with opioid impairment. But in each one of those vignettes, roughly 600 people each got at random one of these different terms. It's describing the person as having a chronically relapsing brain disease, a disease, an illness, a disorder, or a problem. So what happened? Interestingly, what we found was some different nuances, which actually reflects the same kinds of findings as I presented from the mental health field. It looks like when you utilize terminology which has the more gravity, the more medically oriented language, in this case, chronically relapsing brain disease, when the person was described as having a chronically relapsing brain disease, stigma, the blame type of stigma, actually decreased. So it did actually work. When you describe it, you see on the right-hand side at the top, when you describe the person as having, with opioid impairment as having an opioid problem, the stigma tends to be the highest. But look down the bottom. The opposite is true when we think about the dimension of prognostic optimism. Can somebody get well who has opioid impairment? Well, again, it depends on how you describe it. When we describe the opioid impairment as a chronically relapsing brain disease, that person is viewed as the least likely to actually recover from that condition, as opposed to describing it as describing the same person as having had or having an opioid problem. So interestingly, it suggests that the term that we might want to use, there's not one universal term that can address all dimensions of stigma, but rather we might want to think about which particular term in which circumstance is best to address which dimensions of stigma. To reduce blame, for example, stigmatizing blame, we might want to emphasize the medical terminology or the medical way of describing these phenomena. When we're talking about recovery, prognostic optimism, when we're talking about social distancing and danger, we might want to think about using less medically grave terms and more lighter weight or more general terms like problem, which seems to be associated with better prognostic optimism. I think the other thing to remember when we're talking about substance use disorders is that they are actually good prognosis disorders relative to practically any other psychiatric disorder. Roughly 75% of people with a substance use disorder lifetime will achieve full sustained remission. And I think that's important to get across when we talk about, however we talk about the nature of these conditions, that these are preventable, they're treatable, most people recover. It can take a while to get into recovery. It can take many years and many treatments for some people to achieve full remission, but most people will remit. I'm not discounting all the tragedy of the deaths from alcohol, from opioids, from other drugs, but these are, majority of people do recover. We need to do much more, of course, to intervene earlier to prevent the tragedy of these avoidable deaths. So what else can we do? Well, one of the other things we can do is shift our language and terminology. And I've done quite a bit of work in this area, looking at how our use of different terms affects our implicit and explicit biases towards people who have these disorders. So in terms of terminology, there is a vast array in our field of different terms that are used to describe both the conditions as well as people who have them. So you're probably familiar with many of these terms: addiction, dependence, abuse, harmful use, hazardous use, alcoholism, problem use, etc., substance use disorder, as well as people who have them: substance abusers, addicts, alcoholics. Some of them are more pejorative, more street-oriented than clinically oriented, but nevertheless an array that have been used both in and outside of clinical settings. I'm sure we're familiar with these. So let me pose this question to you. People with eating-related conditions are always referred to as having an eating disorder, never as food abusers. So why are people with substance-related conditions referred to as substance abusers and not as having a substance use disorder? We never refer to the field of eating-related problems as eating abuse or food abuse, nor do we ever refer to people who suffer from those problems as food abusers. And yet, we always talk about it as eating disorders. I work in the eating disorders field. I have an eating disorder. That's the language that is used without thinking, because it's habitual. We talk about it all the time like that. In contrast, when we think about drug use, a lot of time, until relatively recently, and the world is changing in this regard, I'm happy to say, but we've tended to use terms like drug abuse and drug abusers. Alcohol abusers or substance abusers have been common ways of describing the phenomenon of drug use, misuse, as well as drug use disorders. And part of that, of course, has to do with the way they are conceived and perceived and our attitudes towards those disorders. Does it matter? This is the question that I asked myself a while back, many years ago now. Is it much to do about nothing? Is it just political correctness? Do we need to really worry about this? Does it really make a difference? Now, here's the reason why I think it made a difference and why I've tested this out, is that referring to someone as a drug abuser is akin to describing them as a child abuser, has that same connotation, that they're volitionally acting and abusing something they shouldn't be doing. So they're doing something bad, and it implies that they're engaging in willful misconduct, and that it is their fault, and they can really help it. They're just choosing to indulge in their selfish indulgence at the expense of others. On the other hand, using terminology like substance use disorder just by the very nature of the term disorder, implies some kind of medical malfunction. Maybe that might invoke the idea, the implicit cognition, that's maybe it's not their fault, there's some kind of something that's gone awry, which we know, of course, is true. When you look at those brain images, for example, you can see there is a medical malfunction that's going on in the brain just by virtue of the structural change. So does it really matter? Can we just dismiss this as political correctness? Well, we did a couple of studies looking at this terminology in particular, where we randomized, in this case, in this first study, it was clinicians, roughly 600 clinicians, doctoral level clinicians, mental health and addiction clinicians, experts, in other words, in their domain, to receive a vignette. And in the vignette, Mr. Williams, who was required, and it was a drug court situation, required to maintain abstinence, has relapsed and was up before the judge, who was going to determine what to do next. And the clinicians in this study were asked what to do, what are their attitudes about Mr. Williams, what should happen to him. And interestingly, so in half of the vignettes, Mr. Williams was described as a substance abuser. In the other half, Mr. Williams was described as having a substance use disorder. Otherwise, they were identical. And they were assigned at random to these clinicians. The clinicians that received the vignette describing Mr. Williams as a substance abuser were more likely to view Mr. Williams as in need of punishment, more to blame for his condition, and less likely to be exonerated than the same Mr. Williams, but described as having a substance use disorder. In other words, just exposure to that single term induced an implicit bias, a difference in their attitudes towards Mr. Williams, depending on just how he was described as a substance abuser versus having a substance use disorder. We conducted a follow-up study, a similar study in the general population. Again, the same terminology, pitting substance abuser against a substance use disorder. And look at the differences here. If you describe someone as having a substance use disorder versus as a substance abuser, you're much more likely to agree that they need treatment, less likely to agree that they need punishment, less likely to agree that they're a social threat, that they are to blame for their problem, more likely to view that person as being in need of, should be exonerated, and less likely that they can self-regulate. In other words, they have the inability or an impaired ability to control the impulse to use despite harmful consequences. So this issue of controllability. So what are the implications? So the implications are, even among well-trained clinicians, they are susceptible to having this implicit bias induced just by being exposed to different terminology. So even when we don't mean it, even if we say, well, I don't mean it like that, I'm not using it in that way when I describe someone as a drug abuser or a substance abuser or an alcohol abuser, I'm not meaning any harm by it. The fact of the matter remains is that people are going to be they're going to be biased by hearing that term. It induces this implicit schema, activates that implicit negative schema that's associated with this notion of willful misconduct, as opposed to using terminology such as, for example, substance use disorder. Other terminology that we use in the field that's commonly heard, clean and dirty. I hear colleagues, even where I work in Massachusetts General Hospital, considered to be one of the top hospitals in the world, describing patients' urine results as being dirty or clean. We don't use that kind of language in any other psychiatry or medicine, and yet somehow that street terminology has made its way at the top of the clinical setting. I don't think we need a study to understand the connotation there, the implication of calling somebody's urine or blood dirty or clean. In an attempt to address some of these issues around terminology and the impact that they may have, when we're trying to address probably the most stigmatized condition in society, again, in order to address it more effectively, we have developed a dictionary. It's a play on words, obviously. The dictionary was I started writing about it in 2003, 2004, when I was arguing for a change in our language and terminology. In particular, getting rid of the term abuse. We're working right now on a petition, a national petition, to change the names of the National Institutes of Health and related federal administrations, like the National Institute of Alcohol Abuse and Alcoholism, the National Institute of Drug Abuse, and the Substance Abuse and Mental Health Services Administration. We're trying to change those names to remove the term abuse, because we do know now that those terms, that term in particular, induces these negative biases. Others have shown the same kinds of biases as well in other studies, similar studies to the ones that we have done. So there's good reason to remove terminology like that we know is stigmatizing. The dictionary, which is housed at recoveryanswers.org, that is our Recovery Research Institute website, is designed as a tool to be able to guide writers, reporters, policymakers, and the general public as to what terms mean, what different terms mean in the addiction field, and also which ones alert people to terms that they may commonly hear, which are associated with increasing or decreasing stigma. So if we want addiction destigmatized, I think we need a language that's unified and that also truly reflects the true nature of what we are understanding from the last 50 years of genetics and neuroscience regarding addiction. Happy to say that Google adopted our dictionary as a recovery tool in their Recover Together page during Recovery Month, which was gratifying to see. And Google actually put up some of the recommended language that we've recommended in the dictionary on the Google webpage, is to use different types of terminology to describe people with drug problems. And it has the old terms and the terms to replace it with. And I'll go into a bit more of that in a minute. Also, the American Bar Association, very happy to see them adopt and utilize the dictionary as well, of the American Bar Association. So all attorneys around the country are exposed to this issue of language and terminology and the proper terminology to use, because it does affect our implicit attitudes towards these individuals, and again, can shape our policy at a broader level. I was happy also to present some of these findings at the International Society of Addiction Journal Editors meeting in Budapest in 2015. And they adopted a consensus statement that advocated against the use of abuse and abuser, dirty and clean, in addiction science worldwide in any addiction journal. So that was another major move, again, away from use of stigmatizing language, that we can get it out of our vernacular and lexicon in the public health and addiction world. If we don't write it in the papers, we don't write it in our journals, we're less likely to use it in our language verbally. Good news also, the Associated Press, in their style book revision in 2016, again, recommended against using terms like abuse and abuser and adopting neutral or less stigmatizing terminology like substance use disorder, for example. But many other agencies now, national organizations, medical agencies within nations around the world, are starting to change, because the recognition that our terminology, the language that we use, of course, which drives our cognitive scripts, which activate our cognitive scripts, which affects our attitudes and behavior, is implicit in everything that we do. Our language are the cues that we derive meaning from, that create action patterns. And our language, therefore, is important to change, especially when we know it is stigmatizing and induces these biases. So here's some recommendations on language not to use and new language to use. So instead of saying drug abuser or alcohol abuser, to use person-first language. This has been adopted in the mental health field decades ago. We don't call people schizophrenics, we call people a person with schizophrenia or someone who suffers from schizophrenia. They are not, that's not the whole person. They're a person first. They may have other disorders or conditions, but they're a person first, and the same language can be used in the addiction field. Instead of calling them a drug abuser, they're a person who has a drug use disorder or misuses drugs. Instead of an alcoholic, again, using person-first language, a person with an alcohol use disorder or an alcohol problem. Instead of using dirty or clean, to use appropriate language there, that the urine was positive for a certain drug or was negative for the presence of a certain drug. And again, with other kinds of opioid-related language, heroin addicts, opioid addict, to again, utilize the person-first language. They're a person with a heroin use disorder or a prescription opioid use disorder. So with that, I'll leave you with that. Again, look out for our petition, which we're trying to get signatures for. We have several thousand at the moment, but we are trying to advocate for name changes at the federal level in terms of changing our National Institutes of Health, because those terms, nobody working in those institutes agrees that the term abuse should be still embedded in those names of those institutes, which were created in the 1970s. So they're outdated, the time to change, we're advocating for change. And I think importantly, because they've been shown to increase stigma, those institutes exist because they are attempting to reduce stigma, to increase access to treatment. So it belies their very essence, their very nature, their purpose and mission. So it's time to change them. We need Congress to act to change those names. So we're trying to push for those name changes. So please, if you can help and sign the petition, feel free to reach out to us at recoveryanswers.org, and we can send you the petition to sign. But I want to thank you for listening, for having me, and appreciate it very much. Good luck and thanks.